Our speaker is Dr. Manzar Hoseyn, who is an professor working in Dhaka National Hospital, and he is an AKU trainee. Dr. Manzar is a well-renowned neurosurgeon working at LNH. और आज जो है we'll discuss dorsal lumbar spine trauma, which is a common topic, especially for young trainees. We need to be aware of common radiology findings as we face in ER. So I think welcome to Dr. Mazhar.
Okay, ji. Thank you, Mustafa. Assalamu alaikum, everyone. Introduction has already been done, so we'll skip that and we'll go on to the presentation directly. So the topic that we'll be discussing today is thoracolumbar spine fractures. So why is it important? First is any resident who has seen ER and has seen spine trauma knows that the dorsal-lumbar spine is the most common region which is affected, and most of the patients who present to ER with spine trauma usually have a dorsal-lumbar spine injuries, number one. And secondly, it's a disease of the relatively young people. So people who are active, it's a disease of those patients, and if they are injured, their mobility is affected severely. That's one of the reasons why we have decided to present this. So hopefully by the end of the session, you'll be able to classify the fractures of a thoracolumbar spine, and with the help of CT and MR, and you'll be able to identify different kinds of fractures, and there are different classification systems. You also will have at least some of the familiarity of how are the different classifications helpful and how do they work. So the thoracolumbar spine typically is a region which starts from where the thoracic spine is ending and where the lumbar spine is beginning. So a region from anywhere from T9 to T10 to L2. So starting from T9 or T10 and ending at L2, this is all thoracolumbar junction. And why it's more susceptible to injury? There are certain reasons for that. First, if you notice, the kyphosis of the dorsal spine is changing into a lordosis of the lumbar spine. So the shape of the spine is changing, which means the forces that are acting on the spine are also acting in a different way. The facet orientation, which is the joint between two of the vertebral bodies posteriorly, the orientation changes. So facet, which is coronally oriented in a thoracic spine, becomes more of a sagittally oriented in the lumbar spine. So that is also one of the reasons why it's more susceptible. And then, like I mentioned, that it's a thoracic spine is braced anteriorly with ribs, and it's a fixed segment. And lumbar spine is a free part of the spine, so it's a mobile, the junction of a fixed and mobile segment. These are some of the factors that make the thoracolumbar junction prone to injuries, and that's why it's the commonest place where the spine fractures occur. Okay, for a resident, when you see a patient who has a spine fracture, the first thing that you need to communicate to your senior or your consultants is the spine stable or is it unstable? If the spine is stable, so typically a stable spine, a stable spine is a spine that under physiological forces, if you apply physiological loads, the routine activities of any person, then the spine is able to resist the change in shape, which is deformity. It's able to resist pain. So people usually move pain-free when they are getting up and walking around, and there is no neurological deficit. So if a spine is serving all three purposes, there's no change in shape when the physiological load is applied, there's no pain, and there's no neurological injury, the spine is considered stable. If any of these is not there, then that spine is unstable. The whole idea of the management of spinal trauma is to make sure that the spine is in stable position. which provides the most conducive environment for the neural tissue to recover if there's any injury there. So typically, a spine has bone and it has soft tissue. If the most of the spine of most of the bone is damaged, then that's spine is considered unstable. If a small portion of the spine is damaged, that is considered stable. We'll see what it means. Okay, so different people have tried different ways of classifying spine fractures. If you see, the reason you see different classifications is because there's no single way to classify spine fractures in such a fashion that everybody understands it. It's easy to use and it's reproducible. So there are different classifications available. People have moved over the years from one to the next, and currently the two of the most commonly used classifications are the Thoracolumbar injury classification system and the AO classification system. One of the old classification systems was a Dennis, which essentially considered or divided spine into three pillars: 1, 2, and 3. This is front, this is back, top, bottom. What he actually meant was that the anterior part of the vertebral body, anterior half, along with the disc between the two vertebral bodies and the anterior longitudinal ligament, is one pillar. The posterior part of the vertebral body, along with its ligament and disc, is the second column, and everything behind the spinal canal is the third column. In the previous slide, like I mentioned, if more than one column is damaged, like if two columns are injured, meaning two pillars are gone, that spine is unstable. If only one pillar is gone, that spine is generally considered stable. This was a very simple concept, but it does not take into account other factors also. So people have come up with AO classification system and thoracolumbar injury. Most of the neurosurgical teams um, are using this system because it also gives you an idea of which patient should undergo surgery, and it is probably easy to remember than the AO classification system, but we'll hopefully by the end of the session we'll be able to understand the difference between the two. So this is the thoracolumbar injury classification system, which has three independent predictors. It has morphology of the fracture, which is what kind of fracture it is, the bony injury and the ligament injury. Then it takes into account the posterior ligament complex, which is the this part, the spinous process and the interspinous ligaments. This is the posterior ligament complex, all of this, all these ligaments here. So is it intact or is it injured? And third is the neurological status. Because we as neurosurgeons, when we operate on spine, the most important factor for us is the neurological status. The better the neurological status of a patient before surgery, there is more likelihood that that patient will be in a better position post-operatively. So and every component has a number, and all these numbers are added up, and they come with a score. So in general, if the score is of all the factors is more than 4, it's a surgical patient, and if it's less than 4, then it's a non-surgical patient. The number 4 depends upon the choice of a surgeon. Some of the patients can be managed non-operatively, while others may need surgery. So the different fractures type that has been defined in this system are the compression fractures, burst fractures, translation, and distraction. And the neurological status varies from intact to the complete spinal cord, and the numerical value is available. So you can check it and then you can score it. For all of these, what you need is you need a good examination, a good CT, and an MRI, because remember, soft tissues are better visualized on MRI, and bone is better visualized on CT scan. The bony pillars provide the immediate stability, and the long-term stability for a period of years is mostly provided by the ligamentous complex that are around the spine. So the other classification system that is in use is the AO classification system. It has three components: the A's, the A fractures, the B fractures, and the C fractures. The A fractures have also subtypes. In the thoracolumbar classification, there were no subtypes. They were just compression, burst, distraction injuries, and translation injuries. But for AO classification system, they have not only grouped them into three groups, but there are also subtypes. So for A fractures are all compression injuries, but compression injuries have their subtypes also. So if the compression injury is causing only the fracture of a spinous process or a transverse process, these are considered minor injuries, and they are labeled as A0. If there's only is compression with wedging of one of the end plates, it can be superior or it can be inferior, then it's considered as A1 compression fracture. A2 is also a compression fracture, but if you notice the difference between A1 and A2 is that both the end plates are gone here, but the posterior cortex is intact. It's the anterior part that is gone, and it's a vertical split. So you see it better on a coronal image rather than a sagittal image. It's a coronal fracture where you see a coronal split from top to bottom. The anterior part of the vertebral body is separated from the posterior part, but the posterior cortex of the vertebral body is intact. So this is the A2 fracture. It's called pincer fracture, Pincer, pincer fracture. It can be managed non-operatively, but sometimes it needs surgery depending upon how the posterior ligament complex, which is the posterior part of the spine, is behaving. The next is, these are all compression fractures. The next is the burst fracture. Almost all the neurosurgical residents have seen this. A burst fracture can be a burst fracture involving the superior end plate or both end plates. A burst fracture, what it actually means is that the posterior cortex of the vertebral body, which is close to the spinal canal, is gone. If the posterior cortex is gone, it's a burst fracture. If it involves only the superior end plate, it's incomplete burst. If it involves both the superior and the inferior, it's a complete burst. So these are the compression types: A0, A1s, A2s, A3s, and A4s. And then the B types. B types are all distraction injuries. So distraction injuries are the distraction forces that are acting on a spine. It has three types. One is where there is only the bone is gone. There's no ligamentous injury from front all the way to back. All three columns are gone, but only this bone injury. This is a classical chance fracture described by chance. What it is uh, there's a force. What it is that um, can you hear me? Hello.
Yes, sir.
Can you see the presentation?
Yes, sir.
Okay, right. So the B fractures are the distraction. A fractures were the compression injuries, whereas there is compression injury, where the force is pressing the spine, and distraction injuries are where the force is pulling the spine. So distraction injury can be pure bony injury, which is a chance fracture, or it can be bony and ligamentous. See the difference? The first fracture was involving the vertebral body, the pedicles, and the spinous process, all bone. But here in the B2 fracture, it is all fracture from front to back, but it's not only involving the bone, but also the soft tissues, which are the ligaments. So this is the PLC, or posterior ligament complex injury also. It's a tension band disruption. So this and this is all bone. This is bone and ligament. Remember, if the bones are the two parts of bone are not in contact and they are separated, if you join them in using a brace, then the bone can heal, but the ligaments don't heal if they're injured. So that's why they are important for long-term stability. If the ligament is gone, there's a chance that over a period of time, the spine will not be stable. And third is hyperextension injuries, where which is also a distraction injury, but it's not involving the posterior part. It's involving the anterior part of the spine, the front of the spine. What is happening is the disc between the two vertebral bodies is disrupted. There's the force that is pulling the spine uh, uh, away from each other and is causing anterior injury. So hyperextension is typically anterior injury, whereas the other two injuries are anterior and posterior both. So A has 1, 2, 3, 4, 5 components. First being 0, and B has 3 components, 1, 2, and 3. But C has no components. If you see a patient's scan which has listhesis on it, traumatic listhesis, which means that one vertebral body has moved over the other vertebral body and it's not in alignment, the front movement or the back movement, then that is fracture dislocation. So this kind of injury is a dislocation injury, which essentially means that all the columns, the columns that we discussed initially, the anterior, the middle, and the posterior, or the front and back, all the soft tissues and the bony contacts are gone. So it's highly unstable injury. So A naught is the most stable, and this is the least stable injuries, and everything else is in between. Some of these injuries can be managed non-operatively, and some of them will need surgery. So that's your job or our job to classify them as stable or unstable. If injury is stable, it can be managed with brace or appropriate rehab. If it's unstable, it may need or will need surgery. So, like we saw the TLICS classification system, which has a neurological component in it. Uh, the the AO classification system also has a neurological component along with the fracture classification. So it's just like a cancer classification system where you see the O's and ones and twos and threes. So the NO means there's no deficit. N4 means there is complete injury. The rest is in between. N1 is transient. N2 is radicular symptoms, which is symptoms or signs involving the single nerve root or more than one root, and incomplete spinal cord injury or a cauda equina injury. And sometimes when patients come and has head injury along with spinal injury, then you cannot assess that patient. So they've given it a number NX. So NX simply means that you cannot assess a patient, what kind of injury, what kind of neurological exam he has. You can see still assess the scans, but not the patient. And NO means there's no focal deficit. So there are two components up till now. We've seen that the AO spine has a component of a bony injury and a component of a neurological injury. Where it differs from the TLICS is this third part, which are the modifiers. Modifiers are factors that affect your surgical decision making. Will you operate or should you not operate? What are the comorbidities associated with that patient? What kind of prognosis should you expect if you operate on that or those patients, or what kind of special arrangements you should make before taking the patient to the operating room? So it has two components, M1 and M2. M1 means that the post PLC, which is the tension band or the posterior ligament complex, cannot be assessed even if you have MRI, and but the bony fracture is stable. So the bone has a fracture. It looks stable, but you cannot assess MRI. You cannot assess the tension band, even if you've done MRI. But over a period of these modifiers were developed a few years back with new sequences coming up in MRI. It's hardly a problem. You will, if you're a good radiologist, you will be able to um, uh, uh, identify if there's any injury to the tension band or not. And the M2 modifiers are the comorbidities, ankylosing spondylitis, osteopenia, osteoporosis, burns. These are the factors that affect your decision making when you're considering a surgical option in a patient who has unstable spine. So just a quick revision. The TLICS has three components. the fracture type, the PLC, which is the tension band, and the neurological status. Anything more than 4 is surgical, less than 4 is non-surgical. AO spine has 3 fracture subtypes: compression, distraction, and translation. Every subtype has further subgroups. A has a 1, 2, 3, 4, 5. A not being fracture of a spinous process, isolated fracture, not the main component, and A being the burst fracture. And B has 3 subtypes: pure bone injury, which is B1, chance fracture; bony and ligaments injury, which is B2, and hyperextension injury. So the hyperextension injury is very rare. You'll hardly see it in your practice. It's not common. Uh, these these injuries are common. These two. Um, okay, and there are the neurological components in AO injuries, um, where you can where there's no deficit, or you cannot assess that patient. Everything else in between. So it's all available. When you communicate to your team members, they'll be able to understand um, what kind of injury, what kind of fracture it is, and what is the neurological status, is stable or unstable. So the whole idea is to communicate with other people and tell them when you're calling them, is the fracture stable or unstable? If it's stable, then obviously no surgery. If unstable, then surgical option. So we've discussed minor injuries, hyperextension injuries, compression fractures. What are these when you look at them individually? So minor injuries, which were the AOs, A0 of the, there's no separate component of minor injuries in TLICS, but in AO classification system, which elaborates the fractures in a better way than the TLICS. It has component which is A0, which means that there's isolated fracture of spinous process or transverse process, and there's no associated injury to vertebral bodies or discoligamentous complex or PLC. So these are all stable fractures. Stable fractures don't need surgery; they need bracing if needed. Not in this patient, and some rehab. So burst fractures. Burst fractures. I told you, like they are the fractures of compression. They're compression injuries. May involve superior end plate. May involve both. If it's superior end plate, then the only mention of burst fracture in TLICS, which is thoracolumbar classification system, is just a burst fracture. But in AO classification system, they further elaborated it, and they've divided it into 2 types: incomplete and complete. Incomplete means only superior end plate, and complete means superior and inferior both. So what is different from compression is that the posterior cortex is gone. The posterior part of the vertebral body is gone. If it is gone, it's a burst fracture. It's not, it's a compression fracture. This is how you differentiate between a burst and a compression fracture. If the posterior cortex is gone, it's a burst fracture. It doesn't matter if it's superior end plate or inferior end plate, it's a burst fracture. It's because of the axial loading, which is on a spine, and it involves both the anterior and the middle column. If the tension band is also disrupted, then the posterior cortex is also gone. So how will you identify it on a CT scan? If you look at the sagittal or a axial image, you will see that the posterior cortex of a vertebral body is gone. If it's gone, it's a burst fracture. The differentials are compression and chance fractures. Okay, these are the sagittal images, the sagittal CT and the sagittal T2. This is T2 weighted MR of a patient. What it shows is that the inferior end plate is also involved here. The superior end plate is gone, but what is more important is the posterior part of vertebral body. The posterior part of vertebral body is fractured. The posterior part is gone. It's a burst fracture. It doesn't matter if it's superior or inferior. So next is fracture dislocation, which is also present in TLICS and in the AO classification system. In AO, it's a type C fracture, and in TLICS, it's a dislocation injury. So what is happening here is that, the superior body has moved forward over the inferior body. which what it means is that the anterior and the posterior and the middle supports are gone. So everything is gone. So anterior column, middle column, posterior column, they're all gone. If everything is gone, this is highly unstable injury. So anterior, middle, posterior, all three columns are gone, and um, and you when you look at an X-ray, you probably see that, oh, there's a posterior cortex involved here. So it's just a burst fracture. No, it's not, because you go for the highest grade. The highest grade is, because it's a translational injury, so it will be fracture dislocation. You go for the highest grade first, and then you classify other injuries that are associated with it. When we go to the exercise, we will do that. So what it essentially shows that all the supports, anterior, middle, posterior, everything is gone, and it's a fracture dislocation which is highly unstable. Chance fracture. Chance fracture, as I mentioned before, typically occurs in pediatric population, or a relatively younger patients, and it's a pure bone injury. It starts from the bone and ends on the bone. There are no ligaments that are damaged here. Since it's a bone-to-bone injury, if you provide contact of a bone with the bone will heal. You can manage this, although it's a unstable injury, and all three pillars are gone, anterior, middle, and posterior column. But since it's a bone injury, you brace it, you can manage it non-operatively also. So it's a type B injury, which is a distraction injury. Distraction means the two forces that are pulling the spine away from each other. And what is happening is all three columns are gone. And because whenever you see posterior column involvement, you'll always notice that there is focal kyphosis here. I don't know if you can appreciate this or not, but the straight spine, it should have been like this. But if you notice here, this slight angulation. This slight angulation is focal kyphosis, and this focal kyphosis is a subtle sign that the posterior column is gone. The posterior column is gone, which is the main column in stability. That fracture is unstable. So there is a small fracture starting from the bone here, going all the way there. The spinal process is intact here, but it's split here into two parts. This is the split of the spinal process, this focal kyphosis. Okay, so compression fracture, it's a compression injury like a burst fracture, but what you notice here is that the posterior cortex is okay. Only the anterior cortex is gone. So if the anterior cortex is gone with compression, then that is a compression fracture. Since the other two columns are fine, so it's considered as a stable injury. The posterior part is fine, the middle part is fine, the posterior cortex is intact. So it's a compression fracture, which is A1, but it is stable injury. It does not need a surgical uh, in, uh, intervention, but what it needs is observation. Whenever there is fracture of an end plate, the gradual axial loading that occurs over a period of months to years may lead to focal kyphosis. If that focal kyphosis is causing pain, is not improving, you may offer a surgical intervention to those patients. But this is not common. So, uh, hope you have uh, understood the difference between the AO and the TLICS classification system. One more time, we just go through it, and then we'll go to the exercise. So the whole idea today is to classify the fractures and and uh, and, at least be good enough so that you can communicate easily. So this is the AO injury classification system, which has A0, which is spinal process fractures, A1. These are all compression. Everything that is A is compression. A1 is compression fractures, A2 is split, A3 is burst, A4 is burst. B1 is pure bony chance, B2 is bony and soft tissue with tensile band disruption, and B3 is hyperextension, and C is displacement. And TLIC is compression, burst, translation, distraction. and the posterior tension band, whether it's intact or not, there is numerical value for everything here, but it's not here. So let's go to the exercise. Let's see what we have. So how are we going to do this? So this is, I mentioned, I've classified the fracture for you. I want any one of you to describe what it actually means. So this is a young man who was on motorcycle, had an accident. When he comes to ER, he's complaining of back pain. When you examine him, there is no deficit. This is L1 level, and this is the axial view of the L1 vertebra. What you see here is this. What does it mean? L1, A naught, N naught. Is it going to be interactive?
Yes, it's going to be interactive. And I will ask one of our residents.
Okay. So it's all learning activities. There's no rights and wrongs. Once, hopefully, by the end of the session, we will know more about the classification systems. If it's wrong, no problem.
Dr. Faisan, will you answer it?
Can I answer?
Yes, answer is already here.
Sure. Yes, sure.
The L1A0N0 means that L1 is denoting the level of the fracture. Yes. A0 means it is a minor injury because it is involving only transverse process.
Yes.
And N0 means there is no neurological deficit.
Okay. And if your consultant or senior asks for a TLICS?
According to TLICS score, there is the score is 0 to 3. That is, it is non-surgical.
It's non-surgical. So what it shows is that the AO classification system is describing a fracture in a better way, but overall understanding in one word whether to operate or not is much more. It is easier to understand in TLICS, right? This is one. Okay. What about this? This is another patient who had a history of fall from a height. There's no deficit and only back pain. You see this sagittal CT scan, and I mentioned the problem here. So this is how you classify this fracture, and you have to describe the image and tell me what it means.
This is a fracture of the L3 vertebral body. Should I continue or should we give somebody else the chance?
I'm not hosting it. You guys are hosting it. It's up to you.
So you can continue, and if anyone else to participate, he or she can also contribute to that.
So I'll continue with that. The sagittal CT shows fracture of the L3 vertebral body, and A1 means it is a compression fracture, and N0 again means that there is no neurological deficit.
And TLICS shows that it's a non-surgical.
Yes, sir. Between 0 to 3.
Okay. So, if I want to describe the fracture, just look at the, don't look at the classification, just look at the fracture and tell me what's going on here.
So,
looks like first fracture, according to TLICS.
No, which part of, just be a radiologist, not a neurosurgeon. Just describe the fracture on a CT.
Middle column is involved.
Okay. So middle column is the posterior cortex. Remember,
yes.
Posterior cortex is intact, and it's not middle column. So most of the brunt of the injury is somewhere here. Which part? This is the superior end plate, right? So axial loading has caused the superior end plate to collapse. So its superior end plate is gone. But the posterior ligament complex or tension band looks okay on CT because the distance between the two spinal processes is similar everywhere, and there's no focal kyphosis, right? Next. Okay. So this is a patient with history of fall and has back pain, but there's no deficit. This is the classification of the fracture type. What does it show? What does it mean?
Sir, L3 indicating the level of fracture again,
Right.
and A2 means split fraction as you taught us,
Yes.
and no neurological deficits,
Okay.
NO8.
Okay. And if the TLIC score is less than 4, it's a
It's a non-surgical.
non-surgical. So A2 denotes that it's a compression. A means it's a compression fracture. And
Yes.
A2 means it's a compression fracture of the pincer type, which is the coronal spread. The whole of the front of the vertebral body is gone, superior, inferior plates both. Usually it's a stable fracture, but you need to follow it, because if it collapses and there's focal kyphosis, the patient may need surgery. Right? अच्छा जी, ये क्या है? It's a young man with a history of fall, has back pain and has paraparesis. Ji.
So basically, it's a burst fracture, and N3 stands for incomplete cord injury.
So, A3 means?
Burst fracture.
Okay.
And N3 means incomplete cord injury.
Okay. So there is some neurology. Just take it. If you don't remember it, no problem. There is some neurology. You know, we know the paraparesis means it's not complete, it's incomplete. And A3 means a burst fracture, which it's a burst fracture of it's a complete burst or incomplete burst.
It's incomplete burst.
Because the inferior end plate is
Intact.
End plate is fine. It's a incomplete burst. And anything with TLIC score more than 4 is a
Surgical.
surgical problem. If you notice here, you may find this slight kyphosis here. Slight kyphosis here, and the interspinous ligaments are opened up. But this is not the best modality. If you want to have a look at the posterior ligament complex, MR is the best modality. Achha ji. It's not thoracolumbar junction, but it's a fracture. It's a young female who has right EHL weakness, has history of fall, complains of back pain. This is the assume that this is a T. This is L1 level. How will you classify this fracture? This is the classification already. I've mentioned the classification. Just explain it.
So this is same as previous.
Right.
So it's at the level of lumbar 5.
Okay.
And it's a complete burst fracture with partial neurological deficits.
And the score is more than 4, so it's a.
This is surgical.
It's a complete burst because the posterior cortex is gone, number 1, and both superior and inferior end plates are gone. So both are gone. It's a complete burst. Achha janab. So it's a young female, history of RTA, paraplegic, post trauma.
So this is basically at the level of D12.
Okay.
And it's a complete burst fracture again. Okay. With complete neurological deficits.
Okay.
And TLICS is score suggestive of surgical management.
Okay. So what it is showing that there's it's not just if you there's complete burst here because the superior and inferior end plates are gone. But if you also notice, there's anterior compression also, and there's spinous ligaments. PLC is also gone. So it's complete burst. So the PLC is also gone, which just confirms that TLIC score that it needs surgery. So both of these scores correlate well with the outcome, with the decision making. If you're using AO score or using TLICS, both are equally good if you want to communicate. अच्छा ना, इसमें क्या है? He's a young boy. He was wearing a seat belt, had a history of accident, and comes to you with back pain. G. Anybody?
So basically, we are seeing the.
So just
trans-osseous disruption, which is a chance fracture, and
okay.
patient with no neurological deficits of T11 level.
B1 means it's a chance fracture. It has a B component and an A component,
Yes.
right? So what is happening is this is the fracture level. These are all squared vertebrae. But if you notice, this is not square. This is anterior wedging. So it has anterior compression, which is A1. But since the higher injury is chance fracture, which is a pure bone injury, so we've mentioned B first and A last. It's a BA fracture, and if, as per TLICS, anything that has distraction injury automatically has a score of 4. And if the posterior ligament complex is also gone, it's more than 4. So it's a, although it's a surgical fracture, but like I mentioned that if it's pure bone injury, you brace this child and you keep him braced for, if it's possible, for 12 weeks, you will notice that it will heal. Okay, Janab. इसमें क्या है जी? It's a boy with a history of RTA, was wearing a seat belt, complains of back pain, there's no deficit.
So anyone else to participate, wants to participate? So
हाँ जनाब. So it's mentioned here. Just read it and you will know what it actually means.
So here we can see in the radiology, we are seeing the T12 level.
Yes.
And so there are two components. One is the burst chance fracture is there, and there's a complete bony disruption of the and other thing is that there's also a component of compression injury, compression fracture, जो कि basically incomplete burst है.
तो ये burst नहीं है. इसमें अभी हम इसमें दो कंपोनेंट आ रहे हैं. तो हम पहला बड़ा कंपोनेंट क्या हमारे पास B1. B1 is the distraction injury and A injury is the compression injury. So you're right. It has both components, a B component and an A component. And there's also, since the posterior ligament complex is gone, you will notice that there is a kyphosis here. If you see kyphosis on a scan with a patient lying, because CT scan is usually done with a patient lying, it means that it is unstable, because if the patient is lying and you can still see kyphosis, when that patient tries to stand up with axial load, that kyphosis is going to increase only, it's not going to settle. So with a score of TLICS more than 4, it is
A3 incomplete burst, right? So here, how can we appreciate A3 burst?
So
incomplete burst.
A burst fracture by definition is something that involves the posterior cortex. Okay. Posterior cortex does not have to be superior end plate. It can be inferior end plate also.
So if there is loss of integrity of posterior cortex, it's burst fracture. Right?
So this is burst, but it has also a B component, which is the posterior part is distraction injury. The ligament complex is gone.
Or sir, if either superior or inferior is gone, so they are incomplete, and both are gone, so that is complete.
Yes, if posterior cortex is gone, it's burst. But if both are gone, it's complete burst. If one is gone, it's incomplete burst.
Okay.
ठीक है?
Yes, sir. Thank you.
Okay. अच्छा जी. इधर क्या है? So it's a young female paraplegic RTA. G.
So basically say ये बता रहे क्या the level of, there are two levels involved, L1 and L2.
Okay.
And so one is showing at the level 2 there's a basically a distraction injury, जो है posterior ligamentous disruption भी है.
Yes.
And we can see there's widening of interspinal distance, and there's a complete collapse of vertebral body, and
Excellent.
to have posterior cortex disruption be
Okay.
okay. And at the level of
So it's a bit of confusing, right?
yeah.
वो क्या रहा है इसमें? Whenever we talk about distraction injury ना, दो spinal process हैं. There's superior spinal process, and there's a inferior spinal process of the 5, 4, 3, 2, and 1. So distraction is happening between L1 and L2, right? The distraction is happening between L1 and L2. That's why the L1, L2 spinal processes are away from each other. This is where the distraction injury is happening. They've mentioned the level L1, L2, B fracture. L1, L2, B fracture. And because the posterior cortex is also gone, so it's an A fracture also. It has, and both superior and inferior inflex are gone, so it's burst fracture. It's a burst with L1, L2, B fracture. This is the level where this distraction is happening. Distraction will happen between, if it's chance fracture, it is happening at a single level. But if it's other kind of injury where the ligaments are also involved, then it's happening between two levels, two vertebral bodies. So a single motion segment, which is two vertebral bodies and soft tissue in between. That's why they mentioned L1, L2, B fracture. So yeah.
Sir, what does that L2 means, which is after B2?
So what they're saying is L1, L2, B fracture, which is L1, L2 distraction injury. समझ आ गई? Clear?
So that L which is after B, like
Right,
B2,
right.
L2,
So this is
before
clear?
A4.
ये clear हो गया? L1, L2, B समझ आ गया?
Yes, sir.
अच्छा, अब L1, अब L2, A भी है. अब they're talking about the vertebra itself. L2 level है जो कि vertebral body is fractured. And what kind of fracture it has? It has A4 fracture. A4. समझ आ गया?
So yes, sir. So basically, so it's a L1, L2, a distraction injury, but there's a loss for posterior cortex also disrupted. So we also giving the compression pattern as well. So ये जो है A4 है, which is a complete burst injury.
L1, L2 is telling you where the distraction is happening. It's happening at L1, L2 level. But because of that distraction, one of the vertebral bodies is gone, and that vertebral body is L2. And what is happened to it? It's an A4 burst fracture. अब समझ आ गया?
Yes, sir. Thank you.
ओके, आगे चलते हैं. ये इसमें क्या नजर आ रहा है? लिखा written it. तो अगर आपने ऐसे देखना है तो don't be confused. इसका मतलब ये होता है. So it's a history of RTA, severe back pain, no deficits. And the score of 4 with thoracolumbar classification. What does it show?
So it's again showing the distraction injury at T11, T12, and
Yeah.
there's a ligamentous disruption as well.
Right.
We can see there's widening of the spinal distance.
Yes.
And at the level of T12, there's a compression fracture,
Yes.
which is A1, which is a stable, and there's no neurological deficit, so N not.
Yeah. Subtle compression fracture, not a lot. बहुत मामूली सा है, थोड़ा सा compression. But so first thing is telling you where the distraction injury is happening between two vertebral bodies, and the second thing is telling you what is happening to the vertebral body that is fractured. And क्या करेंगे इसमें? With a TLC score of 4, what will you do?
It's at surgeon's discretion.
Meaning what?
Means we can either manage it surgically or non-surgically. I think.
So if you want to manage it non-surgically, idea है क्या कर सकते हैं इसमें?
Brace use करेंगे.
Okay, brace करने के बाद कितना अर्सा यूज करेंगे?
At least 4 weeks, and then we'll get the flexion extension use dynamic study. to look
हम
for.
स्टडीज करते हैं हम, तो उसमें हमें लगता है अगर हम स्टैटिक भी कर लेते हैं, स्टैटिक में लगता है कि द फोकल काइफोसिस इज प्रोग्रेसिंग, तो क्या होगा, क्या करेंगे?
So then it becomes a surgical indication if there's a progression of deformity.
जी बिल्कुल, तो देन इट कैन बिकम अ सर्जिकल इंडिकेशन, राइट, गुड। अच्छा जी, इसमें क्या हो रहा है जनाब? It's a patient with a history of ankylosing spondylitis and has trauma and is paraplegic. This is what is happening here. Who will describe this?
तो सर इसके अंदर L1 L2 के लेवल के ऊपर हाइपर एक्सटेंशन वाली इंजरी है, दैट इज B3,
Right?
और M2 सर मुझे याद नहीं आ रहा, M2 क्या था?
Okay. So M2 is something that is a modifier.
Modifier.
ठीक है ना? अच्छा, और इसमें न्यूरोलॉजी भी आ गई है।
M3 भी हो गया।
It is a modifier. Modifier is a comorbid status. M2 is कोई comorbidity है, जैसे just a second. ये इसमें M2 comorbid status इस पेशेंट को ये है, ठीक है?
Oh, okay, right.
It's a modifier. What this score is telling you that the patient has the patient has he has some kind of problem, which is ankylosing spondylitis. He had hyperextension injury, which is a rare thing. Usually happens with these kind of patients. जिनको fuse vertebra हो गया ना, इसमें what is telling you. So when you operate on those patients, if you want to, then this M may help you. If more than one column is gone, it's a surgical problem. The score is more than 4, then patient needs surgery. इसमें वैसे if you look at the fracture itself, क्या नजर आ रहा है इसके अंदर? No scoring, just a CT.
Is a large gap between two vertebrae.
Right, that's one thing.
बट कोई फ्रैगमेंट पीछे पोस्टीरियर कैनाल में तो नहीं जा रहा, तो आई थिंक डीकम्प्रेस करने की शायद जरूरत ना पड़े।
हाँ, नहीं पड़ेगी, गुड। सो anterior part में there is a large gap which is a sign of hyperextension injury. Second के inferior vertebral body is detached, सही है ना? And posteriorly the posterior tension band is gone, right? चलो जी, इसमें क्या नजर आ रहा है? Ankylosing spondylitis, RTA, bilateral foot drop.
तो इसमें सर L4 L5 के लेवल पे ट्रांसलेशन है, और साथ में जो है वो इसको हाइपर एक्सटेंशन इंजरी भी है इसी लेवल के ऊपर, and once again there are comorbids, ankylosing spondylitis or anything like that, and there is severe neurological deficit, probably paraplegia or foot drop at this level.
Okay. So इसमें क्या हो रहा है कि the cause of this ankylosing spondylitis, the patient had extension injury, and उसकी वजह से इसके बाद इसको the highest level of injury is C. So you always mention the highest level first because the superior vertebral body is translating over the inferior. ये आगे है, ये पीछे है. C is first thing. Then comes the B component, that's hyperextension component, B3. Or M2 means there's a comorbidity here. If more than 2 columns are gone or 2 columns are gone, it's unstable spine and needs a surgical intervention. इसमें क्या नजर आ रहा है? This is very easy. Young male fall from a truck and is paraplegic.
It's again a translational injury at D5 and D6 with complete neurological deficits.
So इसमें क्या करेंगे? ऑपरेशन करेंगे, नहीं करेंगे, क्या करेंगे? Will operate or not?
TLISS is greater than 4, so operate.
So if you want to operate, how will you counsel that patient?
That would be only for rehabilitation purpose, sir. No neurological outcome is expected.
You don't expect a neurological recovery.
Exactly.
ठीक है जी. अच्छा जी, ये है ये female with history of RTA and is paraplegic. This is dorsal spine. This is the score. Explain it.
So there is this translation injury again at T8-T9 level with paraplegia, I expect, at this level given N4. Baki, I think there is also loss of vertebral height, so that would account for some kind of compression,
Yes, so
fracture.
there's also A injury here. I have not mentioned A, which is my fault. There's also A injury here. ठीक है?
Right.
तो C injury भी है इसमें और A injury भी है इसके अंदर. You always mention the highest grade first and then the next grade. अच्छा जी. अच्छा एक दो MRI भी कर लेते हैं because time हो गया आप लोगों का almost. इसमें क्या नजर आ रहा है भाई? This is MRI. कौन सा image है ये?
MRI T2 scan.
Sequence कौन सा है? Sequence T1, T2.
Sir, T2 fed set.
It's a T2 segment, T2 sequence sagittal image. इसमें क्या नजर आ रहा है? There's no scoring here. आपने खुद बताना है.
So basically, there's a vertebral body collapse here, and the posterior cord is also disrupted, causing cord compression, thicker indentation, and we can see hyperintensity in posterior ligamentous complex, indicating disruption of posterior tension band as well.
Okay, so is it stable or looks like stable or unstable?
It's basically unstable and requires surgical intervention.
Yeah, so there's slight, I don't know, there's slight kyphosis here, very subtle, and this is gone. यहाँ ज़्यादा नजर आ रहा है, हल्का सा यहाँ kyphosis है. So posterior is gone, anterior is gone, and there's also stenosis of the canal because of the fragment pushing into the spinal canal. इसमें क्या है? Who will answer? इस MR पे क्या नजर आ रहा है?
That's again a compression fracture. With
sequence MR sequence है ना?
Okay, yeah. So T2 sagittal image, right side and of dorsal spine, and which shows a compression fracture of dorsal vertebra. Can't say the level, but it has some retrobulging into the canal, causing cord compression and kyphotic deformity in the proximal to it.
So you can't say compression fracture, you will say compression injury. A fracture कैसा है वो आपको नजर आएगा CT के ऊपर ज़्यादा बेहतर.
Right.
So there's some kind of compression injury here. अब वो कैसी है वो आपको नजर आएगा on a CT scan. The posterior complex looks okay, but if there is a kyphosis, you should be suspicious. ठीक है?
बिल्कुल सर.
Okay जनाब. अच्छा जी. तो ये जो है ये एक छोटा सा इसका revision है. A0 is this is AO classification system. Because we don't use it often, हम ज़्यादा TRICS करते हैं इस्तेमाल, तो इसलिए इसका I'm focusing more on AO. तो इसमें A0 is insignificant injury, A1 is best wedge compression, A2 is pencil fracture, A3 is incomplete burst, which has only one end plate involved, A4 is complete burst, which has both end plates involved, and transosseous is chance fracture, which is all fracture through and through from front to back, but only bony component. It's monosegmental, so you don't mention L1, L2, L3, L4. You only mention L1 chance, L2 chance. But if the osteoligamentous complex is gone, then you have to mention L1, L2, or T12, L1, because more than one bone is involved, the body is involved. And B3 is hypertension injuries. If there's a listhesis on a scan, it's a translational injury. So, so it doesn't matter if you're using AO system or TLIC system. Just remember, morphology of a fracture, the tension band, and neurology all combined together will give you the best classification. And it's always good to follow algorithm, because this helps you to just go back and review what you've done previously and can improve on it or not. Sure enough. So any questions?
Thank you so much, Dr. Manzar. It was a very well-organized interactive session, and thank you for educating us. So actually, we are running out of time. So participants are requested to fill the feedback forms.
Dr. Mustafa, can I ask a question to Dr. Manzar, please?
Yes, sure, please.
जी डॉक्टर मंजर, बस ये बता दीजिए कि जो जैसे TLS स्कोर है, इसमें अगर के दो एडजेसेंट लेवल्स के ऊपर हमारे पास इंजरीज हैं, so would they add up in the score? somehow.
Example.
For example, let's say L1 का भी compression fracture है और L3 का भी compression fracture है. Individually इनका score 2 बनता है. Deficits नहीं है. But अगर ये दोनों alternate या adjacent segments के ऊपर हैं, so would that add up to instability?
So compression is a compression. It will not.
Right, even if it's adjacent segments.
Compression is a compression.
Right. Okay. All right. Thank you.
So, thank you again. So now we can end the session, and Zoom link will be available for those who need to fill the feedback forms.
Thank you.
Thank you very much, sir.
Allah Hafiz.
We'll see you again. Allah Hafiz.
Allah Hafiz.